Welcome to Thriving in Chaos, Episode 2. I'm super excited to be here. I'm your co-host, Dr. Stephen Dion, and I'm with the lovely, elegant, and poised Dr. Sabrina Fabi.
Hi, everyone. Welcome.
We're super excited to be with you today. This is Episode 2. The first one was so popular, we're back by popular demand.
So thank you all for tuning in. We really appreciate all of your support. It's been super exciting to be able to get into the comfort of your own homes and into your offices for those that are watching.
And once again, we're going to do a live didactic presentation followed by questions and answers. So write down your questions now so we have them during the didactic, right when it finishes the didactics. And then we're going to go to live injections.
Yep, where Dr. Diane is going to be doing his injection techniques, which are a little different from mine. And so that's I think the difference between us is that we do things a little differently. But
no, we do things a lot differently.
Okay, fine. But we all know who does. So anyway, this way you can kind of learn from, the lens of a facial plastic surgeon to the lens of a dermatologist, since we, from a discipline standpoint, learn a little bit differently, but we can all learn from one another.
I think that's a really good point, because as a facial plastic surgeon, I'm always thinking about the anatomy up. And as a dermatologist, I think you're thinking about the skin down. So we come from two different perspectives. So sometimes we may disagree, and we have to find that common area where we can agree.
And be able to then impart that education to everyone else. There is a chat function that I want you to get familiar with at the bottom of your screen, and that's where we want you to be putting in your questions so that we can take them. And you can put them in as you see the presentation so that we can make sure that you are completely clear with anything that I present during the didactic portion.
And then you're going to go through a presentation, or you're also going to go through an injection with your patient as well.
Right. So after Stephen does his injection, then I will be doing mine. And today's focus, different than last time's, is to really focus on combining biostimulators with hyaluronic acid fillers. Last time we focused on the combination of biostimulators with energy-based devices, and we will be carrying that on in one of our future episodes. But for today's purpose, many of us inject biostimulators, many of us inject hyaluronic acids, and many of us inject neurotoxins. And there's not a lot of literature out there to talk about how you can safely combine them on the same day on the face. And so that's really where we are drawing from our expertise on using these modalities to be able to educate you.
And what you can see today are things that we do in our clinical practice every single day. Plus, we're going to show you how we get around the COVID, because things have changed a little bit with COVID. You're going to see fantastic anatomy. I know your presentation has anatomy in it, so you're going to see some great anatomy. And then we'll also talk about some of the studies we've done. So the information you're going to get today is going to be very current, very relevant, and it should make a difference in your practice tomorrow.
Yeah, because ultimately we are injecting around blood vessels. So there's definitely an artistic component to what we do, but we're navigating that artistry through many blood vessels. If there is live skin, there is absolutely a blood vessel that's oxygenating in it. And so we have to be respectful of that tissue. And so we will be imparting pearls as to how you can avoid certain blood vessels, some riskier than others, as we navigate the external carotid artery system with that of the internal carotid artery system.
I guarantee you will get tips and pearls from this presentation tonight that you can use tomorrow, or else she'll buy you a bottle of wine.
He'll buy you a bottle of wine.
Okay, so are you ready to go to your presentation, your didactics?
Yeah, so I hope you enjoy the didactic portion of this presentation.
So now we go to Dr. Fabi's presentation, and we will see you afterwards for questions and answers. Please list your questions. We'll be ready for them in a few minutes.
Bye.
Bye.
Good evening, everyone, and welcome to Thriving in Chaos, Episode 2, where we're going to cover an update on performing panfacial biostimulators with hyaluronic acid fillers, as well as neuromodulators. These are mine and Dr. Stephen Dion's disclosures. Medical Education Resources is the CME provider, and the content managers have no conflicts of interest to report. This activity has been generously supported by an educational grant from Galderma. And you can get CME credit for participating through this event. MER is accredited by the ACCME to provide continuing medical education for their physicians. You can receive up to 2 CME credits for today's webinar. How to obtain them? Check out today's webinar, then complete the post-activity evaluation at www.cmesurvey.site/episode2. And a certificate of participation will be issued 1 to 2 weeks following the meeting. There will be a question and answer at the end of the program, basically at the end of this presentation, and then again at the end of the program, and then throughout the entire live demonstration. So don't worry, you will have plenty of time to answer your questions, but we do encourage you to definitely participate. And please don't take any screenshots of the material being presented at today's webinar. The learning objectives is to be able to discuss new protocols that you could have in place for patients in a pre and post-treatment in this COVID environment, how to properly dilute PLLA with sterile water, and best practices for injecting it into the subcutis. Also, how to safely and effectively inject the lips, cheeks, jawline with hyaluronic acid fillers, specifically using cannulas. Many of the products that we will be using will be utilized in an off-label manner, and it may contain a discussion of published or even investigational uses of the agents that are not indicated by the FDA. So how are we going to cover today? We're going to first go through an overview, an introduction, then I'm going to be doing this presentation. You will see us do a treatment, how do we prepare that patient for treatment, and then a Q&A. So why are we talking about these products to begin with? Well, we know that as a function of age, we start to lose bone at the age of 25. That bone loss becomes significant by the age of 35. The symptoms that manifest as a function of that bone resorption are what patients perceive as a tear trough from an orbital widening, as well as a nasolabial fold from maxillary inward rotation. In addition to these deficits that patients perceive, you also have a more feminine face becoming more masculine as soft tissues lose their bony structure along the zygoma and the maxilla and become more bottom heavy with age, as well as men becoming also less masculine as a function of age. If someone already has a genetically weak maxilla, the cheek will just flatten even more, and a nasojugal fold may even be prominent in these subjects in as early as the age of 25. For those that have a weak mandible, they may already have changes of an orange peel or a hyperactive mentalis that no longer has the muscle to support, no longer has the bone to support that muscle when they're young, but only worsens as we lose bone. Once we go into menopause, we lose 30% of our intrinsic ability to create new collagen type 1 as a function of menopause and as a lack of that estrogen. And that collagen is not just making up our dermis, but it makes up the fibrous septae that run from that dermis to our fascia, as well as our fascia, as well as bone. Muscles like to always find a resting tone. And so we've been frowning, laughing, raising our brows all of our life, but at the age of 25, we start to notice lines form, probably at the end of the day after we've been utilizing those muscles quite a bit of time, because those muscles no longer can find a resting tone after contracting. At the age of 35, that bone loss becomes significant, and so some of those more dynamic rhytids become static as a function of age. Some studies have shown that the first fine line develops at the age of 33. And so these are all changes or areas that people come in complaining about based on the underlying bone that supports the muscle, whether it's the procerus, corrugators along the glabella, the frontalis bone, whether it's the orbital bone, the nasal bone to support the nasalis muscle, whether it's the maxilla to support the levator superiorus labialis, or whether it's the orbicularis oris creating our perioral lines, and even the mentalis creating an orange peel. Now, for those that have a weaker mandible, they may notice that they have a more prominent masseter at a younger age, but as that mandible resorbs, it's not just our grinders and clenchers that have an overactive or hyperactive prominent masseter, but we may see masseters get larger as a function of mandibular bone resorption. as well as a platysma, which has been found and which we published on, that can be recruited as well when someone is grinding. This overactivity of the platysma can cause a downward pull of the face, as it is our largest facial depressor, and it interdigitates with the depressor anguli oris, as well as the mentalis, DLI, and even the orbicularis oris, as was found by a study that was published by Ada Trinidad and Jean Carruthers. As a function of age, fat can also reposition. In one study, the only true fat pad that actually diminished as a function of age was the buccal extension of the buccal fat pad, and that typically occurred at the age of 55. And then the skin. We know that we're losing our intrinsic ability to create new collagen production about 1% with each year of life. And fibroblasts are responsible for this production, as well as the production of elastin fibers, hyaluronic acid, cytokines, and growth factors that all slow with age, as these fibroblasts lose their structure, kind of curl up and become more senescent, especially in our 40s. By the age of 60, we have altered microRNA, which has been shown to cause abnormal cell adhesion, collagen synthesis, compared to those that are just less than 10 years old. And in a study looking at 83 biopsies of sun-exposed specimens, they saw an 82.5% decrease in collagen type 1 and 53% decrease in the 9th decade of that collagen type 1. Elastic recoil also declines as a function of age, going from 70% at the age of 20 to 50% at the age of age of 70. So not only is the skin getting thin, but its ability to recoil back onto underlying structure is also diminishing. So there's a lot of room for many of the hyaluronic acid fillers that you see. There are many more than this, but these are the ones that are presently approved in the United States. Some of them are approved with cannula, specifically one of the Nasha technologies for the lip, which comes in a 20 mg per ml HA concentration, as well as one of them for the cheeks, which is a Vicross gel that comes in a 20 mg per ml HA concentration. But off-label, many of us use cannulas to inject the face regularly, and there are many publications to support that this may not only minimize bruising, as published by Susan Winkle, because you poke the person significantly less when you're using a 1.5 or 2-inch cannula versus a 1/2-inch needle, but also it can potentially minimize the inadvertent penetration of an artery, has been shown by Tatiana Pavicic and Sebastian Cotofono, and I'll be covering that study in a little bit. And so these are many of the products. Most recently, one of the resilient HA types has been approved in the United States and is being also launched. So there are many HA fillers with various indications, from cheeks, which include 2 HA fillers, to lips, where we have many HA fillers that are presently approved, to nasolabial folds, marionette lines, perioral lines, as well as most recently, the chin. And these are the biostimulators that we have on the market. Many with varying microsphere sizes, but basically ranging from 20 to 60. 2 of them that are considered almost semi-permanent, lasting no more than 18 months to up to 25 months. And then another one, PMMA, which has been shown to last up to even 5 years. This is not only approved for NLFs, but also for distensible atrophic facial acne scars. And so these fillers, as we know, we're losing bone and our skin is getting thinner and fat is repositioning. So there's a place for these fillers, but they're more than just restoring volume. There's a place for them in biostimulation. And one of the studies that was done looking specifically at hyaluronic acids and their ability to stimulate, potentially have some osteogenic effect, came out of Japan with one of our colleagues, and then one looking at its ability to biostimulate the skin came out from Kwan in the JID in 2013. And the thought that when you inject HA, any HA, in this study, they were specifically looking at a NASHA gel, was that it potentially increases the mechanical forces in the skin and then causes an elongation of fibroblasts, which stimulates them to upregulate type 2 TGF-beta receptor and connective tissue growth factor, and increases cell signaling to potentially cause fibroblast proliferation and an induction in collagen type 1. And this induction of collagen type 1 is thought to not just occur at the dermis, where we've seen that you can histologically confirm that, but also potentially in the bone. Although there are no studies to confirm bone biopsies, in orthopedics, they commonly use a combination of HA with calcium hydroxylapatite and PLLA to have increased osteogenesis. In one study that was done by Mashiko in PRS in 2013, they injected hyaluronic acid along the bone, specifically the zygoma and the maxilla of subjects, and followed them for 12 months. And they did MRIs prior to injection and then after injection. And what they found was that 86% of the treated sites showed a 50% increase in volume retention even at 1 year. 50% showed some level of retention, 75%, 49.5% showed more than 75% retention of that product. And MRI revealed that the HA was replaced with some other material, possibly ossification or calcification along that periosteum. So it's not just the volume from the HA filler, but there might be some biologic activity occurring at the level of the bone. And so this is a patient of mine injected with 3 cc's of HA gel, 1.5 cc's along the zygoma and the maxilla, and 1.5 cc's along the chin as well as the angle of the mandible. And you can see that when injected on bone, you don't see this puffy face, you don't see so much of the product, and it can almost actually simulate bone. Here she is about a month later. Now, HA is not necessarily known as a biostimulator, but those are 2 studies that have shown that it may be doing some biostimulation. We know PLLA, calcium hydroxylapatite, and PMMA to have or be more biostimulators. And so PLLA, in one study done by Stein, where they took 21 patients and they injected 1 vial, reconstituted at 8 cc's of water and 2 cc's of lidocaine, so a total of 10 cc's, and injected it to the ventral aspect of the forearm, and did this every 3 months for a total of 4 sessions. Biopsies were taken at different intervals. In one group, 2 weeks after injection number 2, in another group, 8 months after the last injection, and in another group, 2 weeks after or 10 months after the last injection. And what they confirmed is that there was an upregulation of CD68 positive macrophages alongside with CD90 positive fibroblasts. And there was significant collagen type 3 detected near PLLA and collagen type 1 found near the periphery. So that collagen type 1 is kind of building closer and inching and closer to the material itself. And they also saw an upregulation of TGF-beta and TIMP1. The PLLA was still present 28 months after that last injection. So this is a representative patient. She's 31 in the before photo, she's 36 in the after photo, and you can appreciate the quality of her skin. She's maybe had 1 IPL in between, but it definitely does something to that quality of skin. And in her, I injected it both supraperiosteally, doing a little depot techniques along the bone of the zygoma and the maxilla, and then also fanning it along the subcutis. And so talking about PLLA for bone, a lot of the literature is actually more in orthopedics than there has been in aesthetic medicine. But in orthopedics, the thought is, and in one in vivo study confirmed, that there was an upregulation of osteocalcin, calcium, collagen type 1, and mineralization, suggesting a greater osteogenic potential. When you had PLLA. PLLA HA scaffold mix had even higher expressions of this. So there's definitely a potential
biologic role for injecting PLLA, not just into the dermis, but also supraperiosteally. And so you can see on this woman in her 40s that it almost builds that zygoma, it builds that maxilla, it builds some of her temporal bone, all from injecting PLLA. And you can see the longevity of her result. She's had a total of 4 sessions over a 5-year period. Now, how do we reconstitute PLLA? And so in a more recent study that was presented by Melanie Palm, they took 3 batches and they shook them for 1 minute immediately after reconstitution with an 8 cc reconstitution of sterile water. And they did measurements immediately after reconstitution, 2 hours, 24 hours, and 72 hours later. And they checked for the parameters that you see there at all of those time points. And what they concluded was that vigorous shaking for 1 minute dissolves those PLLA excipients and properly without standing time, and had no impact on the PLLA particles. So that perhaps we don't have to reconstitute these products overnight or even as early as 2 hours before injection. Calcium hydroxylapatite. This is another biostimulator that's on the market, and there are studies to show its role in biostimulating the dermis as well as bone. Also commonly used in orthopedics for that purpose. In one study in aesthetic medicine, as performed by Tatiana Pavicic, to see if the way that it was injected had a meaning or an effect on potentially bony formation. In the original trial with HA, they did little boluses along with needle on bone. But here she took a cannula at 1.6 cc's of calcium hydroxylapatite over 3 entry points, and she fanned it over the zygoma and the maxilla. And on the other side, she did little boluses of calcium hydroxylapatite on bone. And what she found was MRI images taken immediately after showed symmetrical distribution of product. And 2.5 years later, the MRI showed no calcium hydroxylapatite, but did see a thickening of that periosteum. So again, suggesting that there might be some changes happening that we can't quite elucidate at this time since we're not biopsying bone of the face. We do know on the skin where we have biopsied it that just injecting 0.1 cc's of calcium hydroxylapatite and then taking a biopsy both 4 and 9 months later can have a profound effect on new collagen production. And in this study done by Yana Yuskokovia, sorry if I'm butchering her name, she compared this with 0.1 cc's of a hyaluronic acid-based gel to see if one stimulated more collagen than the other. And here she showed this was the intensity of staining of collagen type 3. So greater collagen type 3 staining, the blue denotes calcium hydroxylapatite, the gray denotes the HA gel. And as expected, we saw more collagen type 3 initially at 4 months, and that dropped off at 9 months. Surprisingly, with the HA gel, it took a little longer to get that collagen type 3 in that location. When she looked at collagen type 1 in the calcium hydroxylapatite group, again, significantly greater than the HA gel, almost by about 30%, 9 months after injection of just 0.1 cc's of product. And this was injected supraperiosteally behind the ear. And look at that elastin. So what it tells me, and something that we can maybe extrapolate from this data, is that you might be injecting something supraperiosteally behind the ear is really you're on bone at at about 2 millimeters. And so these reactions, these biostimulatory reactions, don't live in a vacuum. Cells are constantly signaling and they're talking to each other at all tissue depths. And so something that you inject in the fat is obviously having an effect in the dermis. Something that you inject on the bone could be having an effect also at the level of the fat, depending on how thick that tissue may be, and even at the level of the dermis where these biopsies were taken, especially when your tissue is only about 2 millimeters thick. So here you can see significant increase in elastin, again, about 20% more elastin formation with calcium hydroxylapatite than with the HA gel. Dermal cell proliferation was specifically when they were looking for fibroblasts using a Ki67 stain was significantly higher at 9 months. It was about the same for both at 4 months. And interestingly enough, when you compare both, you can see significantly greater angiogenesis at 9 months with the calcium hydroxyapatite, and significantly less lymphohistiocytic infiltrate, perhaps because the calcium hydroxyapatite spheres are now being resorbed and there's less of a foreign body material for the body to form a lymphohistiocytic reaction to. But again, if you look at this patient with just 3 cc's of calcium hydroxyapatite, and I just did 1 cc of a CPM-based HA filler to some of the more static little lines, this is obviously more than just a volumizing effect. I mean, you can see the improvement in her quality of skin. This is 4 months after the injection. So there has been room for biostimulation to occur. And then, of course, there's PMMA. PMMA, we know, is an excellent biostimulator. In one study looking at 11 females, 0.1 cc's of PMMA was injected in the lower dermis of the abdominal skin, and 8-millimeter punch biopsies were taken at 1 week, 2 weeks, 3 weeks, and then, 1 week, 1 month, 2 months, 3 months, and then 6 months after injection. And at each time point, 2 subjects had 4 samples taken. And what they saw was that beginning at week 1 and persisting was an increase in collagen type 1, and it peaked at 2 months and diminished at month 3 and 6, which we would expect, because we would expect it to be replaced by collagen type 1, which they saw at 1 month, which continued to increase in its intensity and organization through 6 months. Elastin fiber in this particular study, again, smaller sample size, was inconclusive. And so these products are wonderful, but we are injecting them into the face, and we have to be mindful of the plane that we're injecting it, because we're always navigating around our blood vessels. So I'm going to be covering the blood vessels that we have to be mindful of and where they run their course when we are injecting the face.
So when injecting the face, one needs to be considerate of the anatomy that you're doing your injections around. And so you have your facial artery, that's a branch of the external artery that courses under the platysma and then crosses over at the level of the mandible on bone. It gives off a branch called the submandibular artery that courses through the mandibular gland, which then crosses over with great variation on bone along the mandibular symphysis. So you have 2 points on bone where you have the artery coursing. The facial artery runs underneath the buccinator, and it kind of gives a very wavy course so that people are able to open up their mouth and close without any difficulty. It gives off a branch called the inferior labial artery, which runs deep to the depressor anguli oris along the vermilion border of the lip. At the oral commissure, it's about 2 centimeters from the oral commissure. And here it pierces more superficially above the zygomaticus major to run a more superficial course. Before it runs up to become the angular artery, it gives a branch called the superior labial artery. The superior labial artery runs below the orbicularis oris muscle. At the level of the nose, it anastomoses with the lateral nasal artery, as well as the dorsal nasal artery, which is a branch of the ophthalmic artery. And at this point, you have many arteries running through here, not just those 2, but lateral nasal artery, dorsal nasal artery. At the level of the chin, if we come back, the facial artery can give a branch called the labiomandibular artery, or this artery can also be a branch from the inferior labial artery. It really depends, but these all anastomose. This labiomandibular artery runs between the depressor labii inferioris and the orbicularis oris. But all of these interdigitate and communicate. That's the course of the facial artery. A branch from the external carotid artery. The external carotid continues to come up, running through
the parotid gland, and then gives off the transverse facial artery. The transverse facial artery runs below zygoma on top of masseter to supply the cheek as well as a bit of the masseter. Underneath, at a deeper plane, behind the mandible and behind the zygoma, you have the maxillary artery. I'll denote that with dots. The maxillary artery has a terminal branch called the infraorbital artery, which comes out, depending on how much bone resorption one has had, between 0.6 to 1 centimeter inferior from the orbital rim along the medial limbus. And that is a terminal branch of the maxillary artery, a branch of the external carotid. The maxillary artery has many different branches. It also has a branch called the inferior alveolar artery, which has a terminal branch called the mental artery. That again is along the mid-pupillary line and is found to also give supply to the chin, an anastomose with the submental artery, the inferior labial artery, and the labiomandibular artery. That maxillary artery also has two branches that supply the temple, the temporalis muscle. You will find the posterior deep temporal artery about 2.5 to 3 centimeters posterior to the orbital rim, deep, almost on bone. And you will find the anterior deep temporal artery 1.5 to 2.5 centimeters deep on bone as well, posterior to the orbital rim. It is thought that the posterior deep temporal artery might hug underneath the temporalis muscle, and the anterior deep temporal artery may be found on top of the temporalis muscle, but refer to Sebastian Cotafona's description of this in his manuscript. These are running deep and will come all the way up into the scalp. Again, branches of the maxillary artery, which are a branch of the external carotid artery. And then lastly, the external carotid artery, terminal branch, it ends in the superficial temporal artery. The superficial temporal artery is running, again, the external carotid has been running deep along parotid, but at the zygoma, 1.5 to 2.5 centimeters anterior to the top of the tragus, you will see it course more superficially. And here it will give off the frontal branch of the superficial temporal artery, as well as the parietal branch of the superficial temporal artery, which will provide supply to the scalp. Those are all the branches of the external carotid artery. Now, the internal carotid artery gives us three branches that are relevant to us. You have the supraorbital artery that comes off of the bone, and there are variable descriptions as to where it becomes more superficial. In some people, it can be up to 2 centimeters high. In others, 1 centimeter high. But it runs its course, of course, giving branches all throughout the forehead. 1.5 to 2.2 centimeters from the midline, you will find the supratrochlear artery. Again, it comes off of the bone, and again, it also courses deep on bone with a variability on when it becomes more superficial. It could be, some report, up to 1 to 1.5 centimeters, but there have been even reports that it could run deep up to even 2 centimeters, and again, has many different branches. This is another place where the branch of an external carotid artery may anastomose with a branch of the internal carotid arteries branch, which is the supraorbital. So the supraorbital and branches of the superficial temporal frontal branch artery can anastomose in this area. And then lastly, the dorsal nasal artery is a branch of the ophthalmic artery that comes in and anastomoses with the angular artery. And so for this reason, there are some reports that advocate the utilization of cannulas. I personally in my practice utilize a fair amount of 22 gauge blunt tipped cannulas. And I have changed from a 25 gauge blunt tip cannula because you can see the image to the right, and that was a photo from one of my patients when I was successfully able to get into the infraorbital artery, penetrating it with this 25 gauge cannula. And so this was corroborated by a study that was done here and has also been discussed by Tatiana Pavicic and Sebastian Cotofona, where they believe that it's harder to pierce a vessel when using a 22 gauge than when using a 25 gauge. And with a 25 gauge, it's easier to pierce it when the vessel is fixed and the cannula is coming at it in a more perpendicular angle versus when you're running parallel along the vessel. You just have to be careful because you could also cannulate the vessel if you are inserting your needle, your introducer needle, and then you have a blood coming out and then you run your cannula inside. You might be actually cannulating it. So that's the only caveat with going parallel to the vessel. But if you're going perpendicular, this is what the authors believed. When combining biostimulators and HA gels, there are no published reports talking about whether it's safe or whether it's more effective. But we know that there's a role for both. And so there are precautionary statements on the labeling of filler products advising against the use of treatments that can induce a dermal response with specifically when injecting HA after injection because of the risk of an inflammatory reaction at the site of the implantation of that HA gel. So today you're going to see us utilizing combining biostimulators with HA gels, but I typically will inject them in different areas if I'm injecting on the same day on the same person to avoid the potential of increasing the inflammatory response towards my HA implant. Now we know that it's not just fillers that can restore volume, biostimulate potentially bone and dermis, but that we also have a role for neuromodulators which can not just soften muscles to soften lines and wrinkles, but can also soften muscles to allow us to reshape the face as well as improve the quality of skin. And so more and more, that's how I utilize these products in my practice. And so these are the 4 different products that are available in the United States presently, the vial sizes that they come in, how they are stabilized, their composition, molecular weight, and then the amount of clostridial protein per 100 units. Of note, some of them have more clostridial protein than others, but that does not mean or denote their level of biologic activity when injected. There's no international units when we're dealing with these products. So even though onobotulinum toxin is approved and ancobotulinum toxin are approved at, let's say, 20 units for the glabella, and we have avobotulinum toxin approved at 50 units. That does not mean that we're using 2.5 times more of the same product to get the effect with avobotulinum toxin. Since these units are not interchangeable, there is no standardized international unit. And these are some consensus recommendations that have come out based on the individual units for each individual product that have been published, specifically by Jean Carruthers. There is, and you can see depending on where you are on the face, what you can do as well as on the neck. Today you're going to see me inject along the glabella, the frontalis, the crow's feet, as well as the DAO mentalis, and to achieve a Nefertiti lift that was described by Philip Levy in Switzerland. I will tell you that I use substantially less amounts of these products as you see
put here because my goal again is not to efface every line or wrinkle. I do want my patients to have movement. I am not treating based on a 4-point or 5-point scale that we use commonly for a clinical trial. That's to achieve an endpoint to get an approval. I am trying to treat to be able to soften lines and to retain expression, but also improve quality of skin and reshape the face. And so I'll be discussing that with my live injection. And so you can see in someone like this, she came in asking for filler into the mid-face to lift her lower face. But you can see that she has a more broad lower face, and it's actually more masculine looking because her bigonial distance is the same as her bizygomatic distance. And so sometimes some patients can benefit from reducing more than by adding volume. So with her, I reduced the volume of her masseter, as well as treated her platysma. I used 40 units of onabotulinum toxin to her masseter. In someone like this, you could use 100 units of avobotulinum toxin to the masseter. And that's off-label, of course. And I always treat the platysma for the most part when I treat the masseter. And that's because another paper that we published showed that those that truly grind are sometimes engaging their platysma as well. So I always not only have them clench, but I also have them say E or really engage their platysma, show them their bottom teeth, so I can see if they're also recruiting from their platysma. Because if you only relax the masseter, they may even complain of some jowling, and they're not even lax. This is a 26-year-old. It's just because now they're really the only muscle that they have working other than their temporalis and their pterygoids, medial and lateral, that are engaging in biting and clenching, is the platysma as well. And so you can see how much thinner her neck looks and how much more jawline definition she has from treating the platysma as well. And so you can see her from a frontal. Now her bizygomatic distance is a bit wider than her bigonial distance, giving her a more feminine appearance. And it's not just in 26-year-olds. This 44-year-old patient also benefited from the same treatment. Again, some people can benefit from reducing versus adding. So she wanted some cheek filler, and she could possibly benefit from a little bit along her temple, as well as lateral zygoma, as well as her chin. But we elected to just reshape her face with a little bit of neuromodulator, and she just looks a little bit more lifted. You can see how the platysma is really pulling on her cheek. And some people, that platysma can come up very high. And this is another patient who benefited from both. And now there are some studies to support the potential, not just from an increased satisfaction or better result, but even if you don't have as much mimetic activity on the areas that you deposit your filler, that you may potentially be able to help these products last a bit longer. So this patient had 3 cc of an HA gel injected, 1 cc along her cheeks, and then 1 cc along the back of her jaw, along the jawline. And you can see that she looks better, but when I also treated her platysma and I did neuromodulator to her upper face, she just looks more awake. She looks happier. She looks better. So the combination, there's a role for combination. It's not just fillers that can help us. And so when combining, in a study done by Alistair and Jean Carruthers, when they combined a 24 mg per ml smooth cohesive gel along the lip, and they also combined it with neuromodulator, they did 90 female participants between the ages of 35 and 55. 30 were in a group that just received the neuromodulator, 30 were in a group that received just the HA filler to the lip, and then 30 were in a group that received the combination. And the combination group showed significant improvement in perioral lines, lip volume, marionette lines, and greater satisfaction than either other group alone. And so in conclusion, HA has been shown to be a biostimulator as well, but less than, at least per one study, than calcium hydroxylapatite. Biostimulation occurs not just at the level of skin, but really anywhere that collagen is created, because these cells don't live in vacuums. You can reconstitute PLLA immediately before injection with no difference seen 2 to 24 to even 72 hours before its utilization when using 8 cc's of sterile water to reconstitute. Risk of piercing a vessel with a 25 gauge blunt tip cannula does exist. It is less of a risk with the 22, but there have been 2 reports, although not published, that have been presented at meetings where penetration with a 22 gauge blunt tip cannula have occurred. You can combine the use of HA, calcium hydroxylapatite, and PLLA on the same day, although there are no studies to show that there is an increase in the dermal inflammatory response. But when you inject them, be cautious and maybe don't inject them in the same area. And you can combine the use of HA neuromodulators to increase the effect and patient satisfaction as seen by Jean Carruthers. With that, I thank you, and we will open it up to questions.
Well, welcome back. Hopefully you enjoy that. I know I'm thoroughly stimulated, especially about biostimulators.
There you go. This is your time to ask questions. I know some of you have been putting in your questions as you were watching the presentation, but really we all learn when you ask questions. We as well learn when you ask questions because we appreciate the challenge. So hopefully there were things that prompted some curiosity.
Okay, so please, so do we have any questions? So I have my trusted new associate here, Dr. Coughlin, who's going to read the questions for us.
All right, Dr. Stewart came up with a great question on a recent article in Plastic and Reconstructive Surgery.
Dr. Stewart.
It's about the new article that came out about HA's causing bone absorption.
Okay, so HA's causing bone resorption. That article just came out. In fact, I was at dinner that night. I saw the article. I know I sent it to you. I said, wow, because this is passing around. Everyone's talking about it. You read the article, right?
Yeah, and so this article, there are a couple of things with this article. First, it was retrospective in nature compared to the one that I showed you all that was prospective in nature, where people were actually had MRI scans prior to injection and then followed up for 2 years and had MRI scans after injection. In this particular study with the 80 patients that they looked at, they personally had never done the injections. These are people that had come into their hospital to get other types of procedures, including genioplasties and other things.
Right, so this study showed that when patients had HA put down deep on the mandible, they actually had bone resorption, and they thought it was pretty significant. Now, there was no cosmetic changes, but when they went in to do mandibular surgery, they saw noticeable resorption. And actually, if you look at the photos, it's pretty impressive. But having said that, this is an early study. It's retrospective. You're right. You have to read it with skepticism. I know I've done thousands of injections in the jawline. I've seen nothing like this clinically.
If anything, I've seen people be able to hold the result. I mean, you have to consider the person who needs some type of level of chin filler probably already has some bony resorption. So these people were looked at after 6 months from injection, and this was conducted in China. Many of the products that are approved in China are not approved in the United States. So we can't really comment on the hyaluronic crosslinker that they're using. Many are a little bit more inflammatory than the ones that are approved here in the United States, which are BDDE. And we don't really know what other elements were injected there, what other excipients may be in the HA, the very reason probably why they're not even approved here in the United States.
So, and they listed some of the HAs that were injected. However, it was all based on patient recall, and many of them I hadn't even heard of.
Yeah, and only 33 of those 80 patients were able to even recall what they had done. So although an interesting attempt to look at this, we have to also look at larger clinical trials from our orthopedic colleagues who commonly use hyaluronic acid in addition to calcium hydroxylapatite, in addition to PLLA, to stimulate bone. And they've been using this for many years. And so studies there have actually shown that it stimulates and creates an osteogenic potential. So it contradicts that as well.
So we don't know the answer, and clearly a large double-blind placebo randomized controlled trial is the way to go. So hopefully we'll have some bigger trials in the future so we can answer this. So if any of the companies out there listening want to do a trial, I'm ready to do one.
Me too. Any other questions, Dr. Coughlin?
Yeah, we have one more. Due to the fact that HA stimulates collagen, do you feel there's a time limit on when it could be absorbed or dissolved if it needed to be?
whether the product or the collagen is resorbed.
Both. Do you think that limits the amount of time that you could dilute or dissolve the...
With the HAs.
Correct.
Okay, so HAs stimulate collagen. So the question is, does that affect when you dilute the HA? Okay. Well, I think what we should really look at is there's a study, and it's a great study, and I'm going to highly recommend you get this paper. It's by Shumati, Derek Jones, I think Raj Chopra was on it also. And they looked at using hyaluronidase to dissolve HA. And they looked at both Hyaluronic and Vitrace, which are two names that are the ones that are most commonly used, two brand names, but they're both hyaluronidase. They're a little bit different. One's human-based and one's bovine-based. And they were able to show that they're able to remove HAs, and different HAs responded differently. The particulate nasha ones actually responded quicker, but all the HAs that they injected, that they treated with the hyaluronidase, they were able to get rid of. But even 4 weeks later, and the product had been there for a while, they were still able to dissolve the HA. So HA can be dissolved even if it's been there for a while. And I know personally, I've seen patients who come to me a year to a year and a half later, and they have these blue bags under their eyes.
Especially 10 years later, I've seen blue bags under the eye as the orbit, resorbs. That product no longer has bone to support it, and so that product is floating. And we know Sue Ellen Cox has spoken on this, where the orbicularis oculi muscle almost spreads apart a little bit, and so some of that product can herniate through the muscle, and that's why you see it years later, even though it was properly placed when it was originally injected. And so I would say that that's never stopped me from being able to get rid of the product effectively.
So you will see
10 years
patients
later.
and do hyaluronidase many years later.
Yes, and it's never been a problem. The new collagen formation, which we know from work done by Vorhaus, lasts 15 years once created. So new collagen that's created lasts quite a bit of time. It's more that we continue to cycle through collagen, and the speed at which we're creating new collagen slows down, which is why we need biostimulators.
And also, in my experience with the HAs, while you can get stimulation of collagen, I don't find it to be clinically that significant. And it's usually the result from the HA and the hydrophilic nature of it that's causing the augmentation. And in my opinion, as a facial plastic surgeon, I get many patients who come to me who want their lower eyes treated. And I look at them, I'm like, have you had fillers before? Like my doctor was 5-6 years ago. I'm like, yes, but you don't need your eyes, I need hyaluronidase placed in there to get rid of your blue bags, and that usually treats them. So it's a solution. So think about that if you see patients who are complaining about under eye bags.
Yeah, and it's not always a volume loss issue. There's also a blue vein that can be going under your eye. We commonly close that off with a long pulse 1064 nanometer laser, which hopefully we'll see in our following episode. So things that are dark under the eyes are not always volume loss.
So dark behind the eyes, watch out. You know about dark behind the eyes, don't you?
I have no idea what you're talking about.
Next question.
We have a good question about temple filling.
Mm-hmm.
Number one, what is the preferred method for injecting Sculptra? So which layer? And then where is the cannula entry point?
Okay, so this is a great question, but I'm going to do a live one in a few minutes, so we can talk more about it. But do you want to give your thoughts?
Yeah, so I actually am a big proponent of using PLLA in the temple. That's my preferred product of choice in that area, and I use it with a needle down onto bone, using a very similar technique that we've all learned from Dr. Arthur Swift, where you follow the temporal crest 1 centimeter up from the brow, and then you move posteriorly another centimeter in an attempt to avoid what you saw me cover, which was the anterior and posterior deep temporal arteries that are usually hanging back about 1.5 to 2.5 centimeters from the orbital rim, and then an attempt to also avoid the sentinel vein, which we're going to demonstrate today. So that's my preferred.
We're
going to demonstrate how to avoid it, but that's essentially what I utilize.
And I'll show you my technique in just a few minutes, so we can go through that, and I'll explain it as I do it.
Another safety question. How do you avoid injecting behind the orbital septum with a finger when you're doing this trick shot? So deep to the orbital septum. Okay.
So I do it. Sometimes I do it. Well,
so the question
is, how do you avoid going deep to the orbital septum with the cannula? So many people don't want to go into the orbit, and I completely understand it. And it's something that only a very advanced practitioner can do. However, in my experience, if you don't go through the orbital retaining ligament, which is a reflection of the septum, if you don't go through it, then you'll also oftentimes get a band underneath the lower eyelid, and you'll see a little roll of filler under the eyelid. I think it doesn't look good. So I will pierce the orbital retaining ligament with a 22 gauge cannula and place little droplets along there into the orbit. So I do it all the time. I've also treated patients who've come back post-surgical with ectropion, where one eyelid's going down, and it's a fantastic treatment to put the eyelid back into position. So I will frequently treat in that area, but not all the time, but it's something that I think you have to be advanced to do.
So I don't personally go in there, especially with a biostimulator, just because in that area, then you're going to be really placing your product very superficially. There's not a lot of fat to protect it, and it's going to be essentially probably into orbicularis oculi muscle. And so we know that products that stimulate collagen production shouldn't be so intimately injected near a dynamic muscle, especially in thin areas like around the mouth or around the eyes. And so for that reason, you'll see me when I do my injection technique, how I kind of, know where the tip of my cannula is as I inject.
And I'll show you that technique in just a few minutes.
Next question.
Any questions?
I've got a good question from Omaha, Nebraska.
Omaha, Nebraska.
All right.
We're just getting everywhere, aren't we?
In regards to facial anatomy, how do you advise patients on which area has the most likely chance of bruising? So the lips, or the eyes, or the temples.
Okay, so go ahead.
So I think this is where it's not so much the area as much as it is the technique. And so if you're using a needle and you're going down onto bone, you have the facial vein if you're doing a tear trough on needle down on bone. So to avoid that, then I would approach a tear trough by coming in a little bit more distally, inferolaterally, so that I'm almost under muscle, under SMAS, and I'm avoiding the facial vein altogether. As far as the lips are concerned, you're going to see me with my injection technique as well today, because that's another area that's super vascular and can cause a lot of bruising. And I think that we both agree on something, surprise, that using a cannula can minimize
So every
bruising.
once in a while, you're right.
That's one way to look at it. But Susan Winkle published on how you can minimize bruising by utilizing a blunt tip cannula versus a needle, and that has been my experience. And you'll see me switch over to a cannula on my patient today because she was pretty vascular. Another area that's commonly causes a lot of bruising is over the masseter. If you're doing like little biostimulation to build a lateral cheek in someone who is a runner or more cachectic, or to stimulate some collagen production in someone who has acne scars, like my patient does, there's a lot of veins over the masseter, and so that's another common area for me.
I agree with all those areas. Sometimes you just can't tell. Some people are just bruisers, and that's just the way it is. When we do surgery, there are just some people who bleed and other people who don't. So are they on blood thinners or all those? I'm sure you know that as well. But as far as when you're injecting, there's no doubt that technique makes a difference. I switched to cannulas probably about 10 years ago, and significantly since then, bruising is reduced. Most patients get barely bruised, and it's really a great difference. And I'll show you some of those techniques today to try to reduce bruising. Of course, you can't completely eliminate it, and it does happen from time to time. And I think things like icing before and afterwards help. I'm not sure if you do that.
Yeah.
Do you do anything else? Do you do vitamin K or arnica?
And so in some patients, I mean, yeah, stopping a fish oil or some type of, an NSAID at least 2 weeks before makes a difference. I think oral arnica can make a difference. There are some excellent topical arnica products that are available as well that can make a difference that we utilize in our practice. You're going to see my patient today. I poked her so many times, and then we just applied ice for 20 minutes, and she had no evidence, and we have an immediate after photo. So it makes, icing can also make a difference.
Icing makes a difference, but I think along those lines, and something that in surgery is super important, is holding pressure. And my fellows know this, 7 minutes. Because back in the day when I was in medical school, when you were still like in grammar school, we used to do something called a bleeding time. We used to cut the skin, and then we'd watch how long it took to stop bleeding. Bleeding takes 7 minutes to stop. So if you transect a vessel, it's going to bleed for 7 minutes. Do you really hold pressure for 7 minutes? Probably not. But when you're in the clinic, if you have your assistant hold pressure for 7 minutes, it makes a significant reduction in the bruising, and it helps.
Yep. Thank you for that question. Any other questions?
All right, from Austin, Texas.
Austin, Texas.
Right.
I've never been there.
I've never been there. I really want to go to Lake Austin.
Do you ever use biostimulators such as sulfur radius in the lips?
Biostimulators in the lips.
So that's a contraindication from with both products. And if you look at many of the safety consensus papers that exist, it is a contraindication. So I would highly discourage the utilization.
And the reason why?
Is because these products, PLLA is a more spiculated product, and so it likes to aggregate very well into areas that are more dynamic. And women, probably more than men, use their mouth a lot during the day. That's what I think Arthur
Probably.
And so what does he say, 10,000 times a day? And so that product will aggregate in the muscle. And so that will cause a little nodule. And that's an area where it's harder to camouflage in an area where there might be a deeper or a thicker fat pocket over it. So for that reason, I do not.
And what do you do if you get a nodule?
If you get a nodule, you can, they're usually more palpable than they are visual. That's our experience. We actually are participating in the long-term 5-year trial using PLLA, and we've even seen that with those nodules, they're usually more palpable than visible. But you can, if it's distressing for the patient, you can do intralesional 5-FU, triamcinolone, and saline, and that's what I've used to bring them down. What have
So
you
you
used?
get, I've injected saline. I've actually squeezed on them.
Yeah.
I found lots of little techniques, but the truth is I don't see much of them. And I think since we've gone to a higher dilution of the PLA, you don't really see it much at all anymore. And occasionally I'll inject around the orbicularis, and I haven't had any nodules in the last few years I can remember.
I had a recent patient that came in who was injected at an outside practice. She had very thin skin, had no fat, and it was like bone, it was skin on bone. And she had big nodules of calcium hydroxylapatite because they just did bolus techniques. And so in those instances, I just inject a lot of saline and I mold it. If you do it within the first 2 weeks of injection, it's pretty forgiving and you can kind of allow it to flatten out because you're kind of almost diluting it. I was able to do a repeat injection 4 weeks later and still get a pretty good result. So even though you can't reverse it, although there's that one trial by Deanne Robinson using thiosulfate, injectable thiosulfate to break it down, you can at least mold it a bit if you inject a lot of normal saline. Any other questions?
All right, Dr. Cola from San Francisco.
Hi, Dr. Cola.
San Francisco.
All right, what is the ratio, what gauge do you use for specific cannula? So you have a 22 gauge cannula. For your port, what gauge do you use?
Can I take this one?
Yes,
because
please.
I am a huge cannula fan, as you know, and I've been
Yep.
lobbying for you to use cannulas all the time. I've been using cannulas for quite a few years now. I'm almost strictly 22 gauge cannulas. Every once in a while I'll use a 25 or a 27, but I'm almost strictly 22 gauge cannula. Every once in a while I'll use a needle. I'm a strong advocate for cannulas. I think they're safer. I think you get better results. I think the evidence is overwhelming that they're more accurate. Now, occasionally there's certain parts of the face where you need a needle, and I agree with that. But if you can convert to 22 gauge cannula, I promise you'll never go back.
Okay.
I get you to
I'm a
convert?
half and half. So I like a little bit of both. So I can understand both camps and I do both. But I use an 18 gauge pilot needle when I use the 22 gauge cannula that you're going to be seeing us use today, or you can use a 20 gauge just so that you can more readily enter.
So the hardest thing about doing cannulas is finding the hole to get the.
Yep.
So I know one company in particular makes an Easy Glide, which you can go right through the needle. I don't use that one, but I also am getting older. I'm over 40, so my eyes aren't.
No.
Yeah, I know you didn't.
So great.
I'm sorry, I didn't tell you the truth on it, did I? But my
Not on
eyes
your
aren't
dating
as good as
profile.
they normally are. What used to be.
Mm-hmm.
So I have to wear cheaters now, so to see the hole.
Or you can do a little numbing dot with lidocaine with epinephrine. That will minimize any significant bleeding, and then introduce my pilot needle. And then at that point, there's not a lot of blood coming out, and that usually helps me too.
Yeah.
And we're going to take one last question before we go into live demonstration.
It leads into well. Specifically, this one's from Louisiana, actually.
Louisiana.
Specifically, where do you think a needle is more beneficial than a cannula?
Okay. So
You take this since
Yeah.
you're such a cannula advocate.
so I will use a needle if
The
I'm.
question is, where
Yeah.
do we think that a needle is more?
Yeah, when you have to choose, where do you think a needle is better?
The question is, where do we think a needle may be better? So I'm going to let you.
Okay, so occasionally I'll use a needle. So I will use a needle for the dermis. If I inject into the dermis for fine lines on the upper lip, I may use it. I may use it in radial cheek lines. I also may use it in the glabella area. If I'm injecting the glabella, I'll go into the dermis and I go horizontally in that way. And I know I can see the needle in the dermis, so I know I'm safe because I'm above the vessels. And if there's an acne scar, I may use a needle. And every once in a while along the vermilion border, I'll do a needle also if I really want to get a fine, thin line in that area. So those are some of the areas I may use a needle.
You're going to see me today. I like to use basically little depots along the bone. So I do use a needle to do that. I do like a needle to build the Pagonian, Napian, and Menton of the chin. I do like a needle to kind of build along the bone of the preachial sulcus. I do like a needle. I like a needle everywhere. Where don't I not like a needle? Along the posterior segment of the ramus of the mandible, which is an avascular plane, and Andre Braz and I published on that. So those, and then down onto bone at the level of the temple.
Okay, but you know what Yanni's paper, Yanni van Longum, who published about if using a needle, he did this in cadavers, but going down to the bone, as he pulled the needle out, if he went transected a vessel, product actually went into the vessel. That kind of scared me.
I saw that product went from the sides, that it was measured to go from the sides of the needle, but and it creates a track. But did it actually show that it went into the blood vessel?
But it was cadavers, so it wasn't obviously vivo. But it's something that always I thought about. So even if you transect a vessel, you have to be careful in theory based on that paper. So just another caveat.
But I will agree that I think for intradermal injections, with some products that you need a blanching technique to really confirm dermal placement, that you need a needle. And I agree with you again, perioral wrinkles and vermilion border. I also like a needle.
So we use them both, but I'm more often cannulous.
So with
and
that,
she's a needle girl because she's chaos.
Yeah. Okay. So with that, we are going to go on to live demonstrations. We thank you so much for your question and answers. Please keep your questions coming through. We're going to be taking them while we inject our beautiful patient. And
when we go to break, I'm going to show them now how I do the rinse. So as I get ready for the patient, you're going to see how I prepare the patients now with this new betadine solution, which is a combination of betadine. It's mouthwash, it's alcohol-free, and distilled water. And every one of my patients will rinse with that before I walk into the room. Occasionally, I'll inject their nose with it too. I like to inject their nose with it, but some of the patients don't like it with an atomizer. So I clean out their sinuses, I clean out their nasopharynx, I clean out their oral cavity before I walk into the room. I also do it myself 3 times a day.
And I don't do any of that. But that's the reason why we all have different practices, and that was published on. And so we're more than happy to share the reference with you all for those who are interested in learning more.
Yep, and I'm gonna show you the video now. If you want the video, DM me afterwards. All right, let's go to the video, and I'm gonna get ready.
So today we're gonna make a betadine mouthwash. So we combine a mixture of distilled water, alcohol-free mouthwash, and iodine. So I'll start, we pour them into these cups just for ease of making the product quickly in clinic. So I will start with the distilled water. So we're going to do 40 cc's of distilled water. So we'll pull up 30 here first. So this is where I'll have the final rinse. So that's 40 cc's of distilled water. Next, we'll draw up 28 cc's of alcohol-free mouthwash. And then lastly, we're going to draw up 4 cc's of iodine. And some contraindications to this mouthwash would be a known pregnancy, thyroid disease, obviously any allergies to iodine itself. The maximum anticipated dose is about 0.55 milligrams. We usually have patients swish and gargle about 9 cc's for 30 seconds to a minute in their mouth prior to the procedure.
I'm ready to show you my patient. This is my patient, Melissa, and I'm going to go ahead and show you what I see on her. And there's a lot that goes into this, and there's an artistic component to it, but there's some mechanics also, which I think you can recognize, and I'll point those out to you so it can help you when you're evaluating patients also. So overall, you can see she's a beautiful young lady. She's very symmetric. In plastic surgery, we learn to break up the face into thirds, upper third, middle third, and lower third. And right away, if you do that, you'll see the lower third's a little bit smaller in her. If you look at the fifth, which we take a fifth, which is the width of an eye across the face. If you look at the fifth, she's fairly symmetric, but one of the things you'll recognize as a master, they're really wide there. I'm not sure if you can see it. Can you bite down, Melissa, so you can see that? I don't know if you can appreciate that. So clearly that needs to be treated. And it's an area oftentimes in women that makes them look more masculine. And I see this a lot in those who run or those who exercise. And she is a runner. And in runners too, I often see this temporal wasting here. So even young people, such as Melissa, can have a temporal wasting here. She doesn't have wasting, but it's a little bit thin here. And you see a prominent orbital ridge. So those are some things quickly that I see that masculinize her. As we get a little bit closer and you look at her mouth, look at the downturn of her corner of her mouth. So you see that, and this is something that concerns her, but it's also something that I noticed as well. This is a very important part of making a face more attractive. And many of you, or if any of you follow my papers or studies, you know I write a lot about first impressions, quality of life, self-esteem. This is a critical component to the face. If you can get this to come up, patients will make a better first impression and they'll actually feel happier. And I published a paper 3 years ago showing that with a Nasha product, using a small particulate Nasha product, I can get this to come up and I can improve their first impression and their self-esteem at the same time. So I think that's really important to get that up. It makes the patient look instantly more favorable and friendly. Other things that I want to point out on her, look at her cheeks are not bad. It's a little bit flat here, but this is an area here of the orbital rim is right here. This is the orbital retaining ligament, which goes along here.
And you go through that. You pierce through that
I
orbital.
do, yeah.
Okay, and what products do you like to pierce that orbital retaining ligament with?
I like to pierce it with, I will use a small particulate HA only.
Okay, so not a biostimulator.
No,
Okay,
I don't. So the orbital rim is here, and this is the orbital retaining ligament. And here's another ligament, and this is the zygomatious cutaneous ligament. This area here is where the SOOP sits, the suborbicularis oculi fat is right here. This area frequently gets filled up with fluid, and it's an area that can get festoons. Festoons when you get this malar bag here. And this can be a difficult thing to treat. Even surgically, we struggle to treat it, but if she doesn't have it, but if another patient has this, you have to be really careful because if you put filler in here, HA in particular, you make it worse. And if you combine that with neurotoxin, it's even worse because the neurotoxin weakens orbicularis.
right, because the lymphatic flow goes from the medial canthus to the basically out.
Yes. Okay, temporal adhesion line is right here. So that's where the temporal adhesion, the deep temporal fascia fuses with the periosteum. This is a true osteocutaneous ligament. The zygomatic arch is here, and off of here is the zygomaticus muscle, which is coming up like there. So right in here is McGregor's patch, or the temporal, or this is another true cutaneous ligament right here. This is another ligament. If you follow, and then you also have a ligament right here, and this is very hard to get through. This is the lateral orbital thickening. So these are true ligaments here.
You basically have ligaments that kind of cross all throughout here. So this is almost like the more mobile part of the face, and then posterior to that is the more adhered part of the
And
face.
the third one is right here is the mandibular ligament. And so in surgery, we always want to go through that. So these ligaments, I can mark them with a different color. You have to recognize these ligaments. These are true ligaments. It goes from the bone to the skin. So if you treat the face lateral to those ligaments, the skin will rise. And Gabby Casabona wrote a paper with this with Sebastian and Protopono, showing that you can get significant improvement in elevation of the skin by lifting this area out here. And you need less product medially. Now, medially, when you inject, some of the things you want to recognize is you have the fat pads that Rourke and Pessa talked about. And those fat pads were that landmark article in 2008. There's so many fat pads. I'm not sure I want to get into all of them because I think it's a little bit too much for us to, and I'm sure you've seen them many times.
Do you focus on injecting into each individual fat pad, or are you basically on bone, superficial fat, or deep fat?
So it's a great question. And the answer to that is no, I don't focus on superficial fat pads. It doesn't really mean a whole bunch to me.
Okay.
And I know a lot of people are very strict about it. I just wanted to mention them because I think you should know about it. But I was a sculptor before I was a plastic surgeon. So I look at the face much differently than fat pads. But I think it's something that I should teach. And most importantly is the deep fat pads is below the SMAS, below the muscle layer of the. So, and these fat pads, as you get older, lose volume. So you're looking here at like the deep medial thick fat pad, and there's a medial one, and there's a lateral one, and there's a more middle one, and then there's the SOOP that's out here, and these are like the deep, and then there's a medial SOOP. So these are the fat pads that are deeper. if you inject into this deep fat pad, and this is a critical, if you inject deep into this fat pad, the cheek will vector forward, it'll project, but you'll also get improvement in the infraorbital area. So why is that important critically and clinically? Is because you don't need to always inject under the eye. If you inject this area, you'll get improvement in the infraorbital region as well. And so, but keep in mind that there's another paper by Sebastian. We have so many great papers, Sebastian Codafona, that when you inject in here, only about 30% of what you inject volume, you see that volume increase in this region. In other words, if you put in 1 cc of filler, you see about a 3 millimeter, 1.3 cc improvement in volume, whereas the soup is 97%. In other words, it's almost 1 to 1. You put 1 cc in here, you get 1 cc improvement. You put in 1 cc, you get 0.3 cc's improvement.
Right. So if you're going to do your biggest bang for your buck,
it's going to be here. But if you inject out here first, then you don't need to inject here as much because you'll get a lift.
So when you approach, you always approach the temple first and the lateral.
No.
Okay.
So I approach the cheek first. I'll show you
Okay.
that in a second, how I do that. And then this is the malar space here and the buccal space. This is important here. And you have your DAO, which you know comes right down here. It fans.
Right. It sounds like that.
Yeah.
Yep.
And then your DLI is right here. Okay, so those are muscles. We can do that with different color. So these are muscles here. And then you have another muscle here. Your DLI. So if I'm treating the DAO, which is this muscle, depressor angulus oris, you want to make sure you inject right around there. And then this should help bring this up a little bit, although I don't inject a lot. This is DLI. You don't want to touch this. You don't want to get into this muscle because if you do, the lip will roll up. You'll lose competency of the lip. Now, so this is how many people look at the face. I look at it differently. I look at it in threes. I believe omni, trium, perfectum. 3 is perfect, 3 is perfect, 3 is perfect. I think that we love threes. So I look at the face, I say, okay, I look at threes. Look at the eyes and look at the mouth. Do these balance. I think every feature on the face has to be looked at within the context of the face. So if a patient comes to me and says, doctor, I want to treat my cheeks, I'm looking at the chin. Because if I treat the cheeks and not the chin, it's not going to look right. So look at her. Her cheeks are pretty good. Laterally, she's got a high cheek point, pretty far laterally. Females further out than men. And that's nice. Where's that cheek point? Well, everyone's different, but
If you do like Hinder's line,
yeah, you can, I'll show you.
you want your greatest light reflection.
So your great light reflection is off the cheek. So you can do it. You can come from
The lateral canthus.
you can go right like this to the nasal ala, and from the cross is right there. You're going from the root of the helix to the nasal ala, and then from the lateral orbital rim down, and that's where you would think she wanted. I don't do that once again. That's easy. It's an easy solution. So root of helix, the lateral nasal ala, and then down from the lateral orbital rim. But I look at the face in threes. I say, okay, how do I make her look good? So do the eyes balance with the chin? Do the cheeks balance with the chin? And you see here that the cheeks are wider. They look great. This is a little weak compared to this. I think that's important also.
Another point is basically the base of the nose to the upper lip. That distance is usually about 1/3, 2/3 from the lower lip to the menton.
Yeah.
And you can see that she's pretty much 1 in 1. She's a
Yeah.
1-to-1 ratio. So she could definitely benefit from a little bit of elongation by placing product in her menton, as well as the Mathian, and even a little bit into her Pagonian, because we're also focusing on her profile, which is what you work on all day long.
So I do work on profile all day long. And let's look at her profile. Her nose, we're not treating the nose now, and we can talk about that. Actually, we have an upcoming episode on the nose.
Yeah.
This is an area that I also find that she's pretty good here. But if you want to project the lip forward and you want to raise the lip a little bit, you can actually inject underneath the nose, underneath the base of the nose, in the premaxillar face, risto space, which is this space right here. There's no vessels there. The artery is about a centimeter lateral usually. There's usually a space there that's pretty avascular.
By getting very, very close to the ala.
Close to the ala,
There
down
you
the
go.
bone.
Yep.
So if you get down there, you're usually pretty safe. Some people use a needle. Once again, I don't like needles, and I'll show you that technique. But you can go down there, and you can project the nose forward. And if you bring the nose forward, it actually brings the lip up. Brings the lip up how much? About 4%. And I published a paper on that a couple years ago. So filler under there raises the lip. It's another nifty technique to raise the lip, especially in someone who's got a very thin, elongated upper lip, which happens a lot during the aging
Right,
process.
because we get elongation of the lip because we lose that maxilla. That maxilla is resorbing. And what I see is that a lot of people just keep getting their lip filled.
Yes.
And so now the lip protrudes out, and this is actually almost sunken in,
Yes.
which is where that premaxillary space that you're injecting in.
So that is a great point, and it's often overlooked that we do lose bone as we get older, especially in the orbits and the piriform, and maxilla also goes down. So the skeleton kind of involutes, and we keep putting filler into the soft tissue, but the reality is we go deep down the bone, we get a better result.
Wonderful.
So okay, let's go ahead and clean her off a little bit.
Cleaning her off and start injecting. In the meantime, let's take a look. Your question.
Also, I want to talk about some of the things we're doing in the office to make sure that people are safe. And one of the things that we're doing also in the office is we have a HEPA filter. So we're circulating the air. Every five times an hour, the air is completely circulating with the HEPA filter, which is in the corner. I don't know if we have time to show you that. We'll show you later. We also have a UVC light, ultraviolet C, 260 to 285. And that also destroys the COVID, the virus. So in between patients, we have both of those going. So we make sure the room is completely sterilized. We come in, we wipe it down with panfacial or a sodium hypochlorite solution. And that also helps to make sure that the room is as clean as possible. Patients do wear a mask as they come in. Right now, I was showing you a little bit on her I was showing you the demonstrations. This is something I also do now. These are two 4x4s, and they have been soaked in hypochlorous acid. So I put this over the nose. So when I walk into the room, she's done the rinse, and she has this. So you can see that's my best way of protecting her and me while I'm injecting her. So it might be a little difficult for you to see. So hopefully we'll move some things out of the way. But I want to try to show you how we're doing things in a post-COVID environment, because we are called post-COVID environment here, right?
Yep.
Okay. So I'm going to start out. What I usually start out with when I come into a face, as I said to you before, I know I want to put a little bit in her cheeks. She doesn't need a lot in her cheeks, but she's a little bit flat in the premaxillum. So I'm going to put just a little bit in there. A product that I like a lot is let's start with this. Let's start with Abo. We start with botulinum toxin A first. We do with Abo botulinum toxin A. I almost always do botulinum toxin first. Let's see you found, listen.
So you always do your toxin before you do your fillers on the same day?
Yeah, almost always.
Okay.
You can find, okay, so
I do that a little differently.
Did I give you some treatment recently there? Oh my God, she looks good, doesn't she? I thought so too. Okay.
If you don't say so yourself.
Yeah. Okay, she doesn't need anything clearly there. So I'm not gonna, but I'm gonna do her masters. But usually I do botulinum Abo. For this case, I would do botulinum toxin. I treat the corrugators, the proceras. I think you all know that. The only point I want to make on this is that, raise your eyebrows. You see her eyebrows go up? So she still has function of her frontalis. So I inject her recently. She still has function. Her eyes look good. They're raising. She's not getting those parentheses that form. So I inject the corrugator right there superficially. I go into the dermis.
Okay.
Because the muscle inserts into the dermis, and I think it's a great way to weaken it without taking it away completely. So I'm going to go ahead and treat her masters. So this is the master here. Bite down. Do you see that? You can't miss that. That's like a barn door.
Okay.
Okay.
That's one way to look at it.
There's two heads to this muscle. I have them bite down. I inject it, and I stay posterior. Okay. And the reason why I stay posterior, and I go down into the muscle, I know I'm in the muscle. I'm going to put in about 50 units or 60 units.
50 units of avobotulinum toxin, which would be about the equivalent of 20 units of Pineco or botulinum toxin.
Exactly right.
And I'm like you. How many injection points do you do?
2.
2. I do 3. And I usually do 1 a centimeter posterior to the anterior border of the masseter, again, to avoid getting the risorius muscle. And then I always stay below the tragus in order to avoid getting the zygomaticus major muscle.
So the key is the risorius muscle, which is right about here. If you get this, the patient won't be able to smile. And if she doesn't smile, she's going to be very unhappy with you. She's going to be unhappy. And you're safe to stay posterior. If you end up getting the parotid, so the parotid goes down. In fact, I treat patients who have keratitis. If the cards are huge, or they have Sjogren's syndrome, I treat them with the same thing and they get wonderful results.
Even those with HIV lipoatrophy who are on some of those retroviral medications can get carotid hypertrophy. And truthfully, you almost need 40 units into each carotid to make a significant difference. So doing 20 units into your masseter is going to barely touch the carotid. And we know that the carotid can cross over and cover the masseter about 70%. So we are probably all treating a little bit of carotid when we're treating masseter.
Yes, and that's probably some of the benefit we get now. I have seen people who have been really hollowed out there.
Yep.
And too much, so that's not a good idea. Okay, let's go with the cans. Let's go ahead with the filler. But I do think this is one of the most wonderful things you can treat. Now, I don't know if this happens to you, but patients come in all the time, and if I say, let's treat this area, they're like, no, I love my jawline, but I don't want to touch it. So it's a hard thing for me to get them excited about. It's a hard thing for me to get them excited about, to treat that area. But it makes such a big difference because it takes a female face, feminizes it. All right, so the question I get all the time is, when you treat the cheeks, where are you going to inject? So I wanted to show you here. I'm going to show you a very simple technique that I think. I go one finger breath below the lateral canthus on a diagonal. Okay, so there are many different lines you can draw. You can draw many different lines to try to find out where that highlight is. But I like to go one finger breath, which is about 1.5 centimeters, right there, lateral canthus down, and I put my needle in. The reason why I say is every patient's a little bit different. So you can see here, I have a 20 gauge needle in there. This is a 22 gauge cannula. My assistant pulls it out, and then I have to find the hole, which is always the hardest part. Okay, now I know I'm in there. My non-dominant hand feels where I'm at.
And so you are below the SMAP.
I'm in the deep medial cheek fat pad, for those of you who care about those things.
In the soup.
And the soup is out here, so a little bit in the soup. So I come down here, and then as I do this, I lift up the skin. You see that? I just lift up the skin gently. And then I fan. Now I'm coming here. Lift the cheek up.
So something that I learned from Becky Fitzgerald is this prezygomatic space. And so it's essentially, you're going underneath the fascia of the soup.
Yes.
And pretty much between soup and periosteum. And in some people who are a little bit older and have had zygomatic bone resorption, that space, that prezygomatic space, which has been published in PRS, there's a bit more, it's easier to navigate through than somebody who might be 35. And
yes.
so that's where I like to usually try to get
now,
into it.
You see I'm coming across, here's your orbital rim. The orbital rectangle ligament's right here. You see that? It's your orbital rectangle ligament.
Yep.
I can go through the orbital rectangle ligament. Now this is the cannula. Right there, up through. It was a gentle move. Now I want to show you something as I go through there. Now, can you see that right there?
Yep. So move your finger. I think that way everyone can see chin down. So you can see, yeah, and I usually tense up my cannula so I can appreciate how.
Okay, so I don't want to be that deep, but I'm just under muscle. I'm just going to put little drops under there. So even the large particulate one, I'll do it. And then I'll come up into here. Now, once again, orbital rectangle ligament. I just pop through. I don't know, could you appreciate that? I'm gonna do it again. I'm right there. It's a little stuck. And
sometimes I even wiggle.
You can wiggle too. Same thing. I'll come out here. Now this is a very tough ligament. Just pop through. Now, if you're a beginner, I don't know if that's a good thing for you to learn to do, but this hand is protecting the orbit the whole time. And then I might come down here. I might lift up the space a little bit. And then if I want, I can go into the buccal space down here too. And I can lift up. This is not always how the patient position, so it's a little bit awkward. Can you see that?
Now we can without, yeah.
And I can lift. So this whole thing takes me about.
So from that injection point, you're kind of crossing over, and you're still under. You're under.
Now. Yeah, and this is 70 millimeters. So because this is 70 millimeters, I can reach almost the whole face. Now I do like cannulas. One of the things I like about this cannula is I have a red dot here, which tells me where the port is. And this port is almost 1.5 millimeters from the distal end. So that's a key component for me too.
Oh, good. Very nice.
So you can appreciate that right there.
Beautiful.
Good? Okay. So now I'm gonna come around here to the mouth.
Okay.
I'm gonna show you a technique I have for lifting this up, which I think is really wonderful. Let's go.
And so someone asked, what is the solution on the gauze over her nose? And that is
Hypochlorous acid.
hypochlorous acid.
Okay, so now I'm going to do something here to lift this up a little bit. I'm going to show you a little technique I have for that too.
And so for those who are at home, if you have any questions, we'd love to hear from you.
Okay, so I come lateral to this about a centimeter. So I'm out here. Now, as Dr. Fabi told you, the artery is not too far from there. If I see a gush, then I know I'm in the artery, but I'm not there. And then you see I'm just lateral to the oral commissure.
And this is the benefit of using, you did like these little numbing dots with lidocaine and epinephrine. And so you let that sit, and it almost allows you to know where you should enter with your pilot needle, but it also causes a little bit of hemostasis in the area that you enter with your pilot needle to minimize bruising for the person who had asked previously how to, what areas cause more bruising.
Okay, I want to show you something. This is the labiomandibular ligament. You see this ligament right here. Okay? You recognize that ligament. You all have it. Watch as I go through it. You see how it has to break through, it has to push through. This is not a true ligament. So you can subcise this ligament, which I learned from my dermatology colleagues about subcision. So I come across it, and I put little lanes of product across this.
I usually approach it, and you're going to see later from below, but you like to approach it from above.
Yes. So I'm coming all the way across this, and I have to just go through there just gently. And can you see that?
Just hiding it a little bit.
Okay.
There you go.
And then I come a little bit above the oral commissure right here, just a drop, and I know I'm going to put something in her lips too. And just through there, and you can see how that's subsized now. Now, I proved that this way will make people happier and will improve their first impression. So I know this works.
So in your study, you were able to show that if you can't necessarily you can't frown, then you can't feel sad.
Can't frown, you can't be down.
Okay. So are we going to do that to you?
Fortunately, I'm never sad.
Right.
So you can start to appreciate how that's coming up right away.
Right.
And that's pretty nice.
And it also kind of like elongates that lower lip. Like you can start to see more of that lower vermilion by supporting the depressor anguli muscle and putting that product underneath the muscle.
Okay. Now I want to show you another little trick I have.
Okay.
And this is for, if I'm going to do the jaw, I'm going to do the chin, which I do frequently. Okay.
Which product were you using there?
So I used for that one Nasha, and that was 20 milligrams per cc, which is Restylane. And that's we use silk in the study.
Okay.
So both use Nasha.
Okay.
But I use all kinds of HAs there. That's
yeah.
So now I'm gonna the jawline here. Now she's got wonderful masseters. She doesn't need a big jawline, but she does need chin projection. She needs chin elongation, and she needs this area treated right here.
Okay.
Turn your head this way so we can see better. This is where the mandibular ligament is, right there. Look at the pedonge that she has here. So this area needs some rejuvenation. So I'm going to use a large particulate HA right now. I come just lateral. Here's the symphysis. I'm lateral here. And of course, I have to be careful of the submental artery, which is a branch of, as you explained,
the submandibular artery, which is a
so
branch of the facial.
So
you go a little lateral to the mandibular symphysis.
Yep. And then I get into the plane, and then my other hand is here. Yep. And I find where I want to go. Now, this is a true ligament. This is a true ligament, and you have to kind of punch your way through it, so to speak. And then I'm able to get under it. If you don't get under the mandible, you won't improve this.
Okay.
So you have to get through there.
Because you have to give the support to those muscles that are attaching onto that bone.
Coming along here, and you can really nicely redefine this. Now, I love a hard product for this.
Okay.
I don't use a soft one. So I do like calcium hydroxyapatite.
Okay.
I do like this product, which is a Restylane product. It's lift, but it's a large particulate Nasha. So I do like these products for here. I also use other products as well. We're in studies with products too right now that are showing nice results. And I
So
think you can appreciate that.
is this your filler of choice for the corners of the mouth? Someone is asking.
So I am an equal opportunist,
Okay.
and I use many different products and many different people, and it really, really varies.
Okay.
If someone's a little bit thinner skin,
Yep.
then I might use a product that has a little more pliability to it.
Okay.
And I like some of the products with pliability. You can kind of see that right there, so I really appreciate it.
Yeah, so you can kind of see that it's elongated, that distance between the vermilion.
Well, I haven't even done the chin yet. So then
Yeah.
I'll come here.
Okay.
This is for the chin. So now a lot of people inject right down into the bone.
Right, which you're going to see in a moment, right after Dr. Diane. Yep.
So I like to come down here, and I go across, and I lay.
And so you're basically injecting into muscle at this point.
I'm below muscle, I do.
Okay.
And I'm laying, and I can see this chin project really nicely from here, and I can come down below the chin here a little bit if I want to elongate this. And then I set my chin position, and I'll come to the other side and fill on the other side.
So not everyone can benefit from elongation to the chin. So some people have the length, but they don't have the projection of the pagonian.
Right.
But that's beautiful. That's a beautiful. And how much product did you do to just the chin?
0.6.
0.6 cc's. And that was of wrestle and lift. Okay.
So now, do you see this, the mental labial sulcus? Some people complain about that.
Okay.
So I'm going to go ahead and treat that too.
And you can start to see how smooth this part is, how nice the curvature that's been restored versus how this is almost still curling
Here's
in.
another little trick, mental labial sulcus. Come across there.
And here, I usually don't like to efface it completely because it almost flattens out the chin, especially in a woman. But in a man, I have no problem flattening it out altogether.
You have no problem flattening men, huh?
No, flattening the chin.
Oh, sorry. So
but if they need to be flattened, I will have to do it too. Yes, I can do it.
I'm blending out the mental labial sulcus here. I'm not sure if you can see this.
Okay.
But this is some areas I'll use. Oftentimes I'll use a needle here because you can really efface this nicely with the needle. But I'm really superficial. I'm just under the dermis.
Yeah, so that's important because you guys all saw the anatomy part where you have, and that's a correction on my end, it's the labial mental artery. I called it the labial mandibular artery that can be a branch of the inferior labial or of the facial artery. And that can run in this area, usually under DLI, in between DLI and orbicularis oris. So that's the only artery that you want to be careful of when you are injecting into that mental sulcus using a needle.
See how nice, it looks really nice from my standpoint.
Yeah, it's beautiful. And so you used 6 cc's here, about 0.4 cc's into her pre-gel sulcus. And how much did you just use to
0.4.
In 0.4? And you used Restylane or Restylane lift?
Restylane. So now I'm going to go ahead and treat the lips. She's got nice lips. Now she has.
Her upper lip is a little fuller than her lower lip.
It is, and it's a nice lip, and she's got fine radial lip lines, which is always the bane of existence for many, many people. So I often find that if I treat the vermilion border first, I can get a nice result with that.
Okay.
But I have a special technique for lips. I'm going to show you this technique. I think it's wonderful. Hopefully you guys will adopt it. I'm going to put this here about a millimeter or two outside the oral commissure.
And so the question was, do you combine ligamentous subcision with neurotoxin and the DAO?
Good question. So sometimes I do place toxin in the DAO, but I don't do a lot of it, to be honest with you.
So I do quite a lot. And so you'll see in my video, you'll see after this patient that I pretty much standard do, if the person has a downward pull, I always treat DAO, mentalis, and platysma because we know that the platysma interdigitates with the DAO. And so if you just treat the DAO, you still may have a downward pull extending from the platysma, and you'll see a blunting of the jawline as a result of that recruitment.
Okay, you see my cannula there?
Yeah.
So 22 gauge cannula. This is 50 millimeters. I've been using 70 millimeters up to now.
Okay.
But now I'm using a 50 millimeter. This is the Cupid's bow. I'm in the muscle. Now I can reposition this more superficially. You see that?
Yep.
And I can come just underneath the vermilion.
Right.
But now I can reposition deeper
and you
in the
can
muscle.
see, you can actually see the gray of the cannula.
Okay, so now, and then I just.
And so here you're using an expression technology gel, which is also 20 mg per cc. And that's a product that I really do like for the lip, especially when we're just trying to rejuvenate the lip. because the lip gets a bit smaller as a function of age. You're going to see in the next patient that we use, I use the newest product in the expression technology line that is approved for lips, because in that person, she needed more restoration. She had lost all her volume altogether. So this is a product that you go to a lot for the lip.
So I use the Express technology and I use a particular one. I like them both. I like everything. I use
I think there's a role for a lot of these lip products.
too. I use a lot of these. So I want you to see how this is going in. My fingers can hold it where I want it to make sure I'm in the right place.
So there was a question about whether you're changing cannulas for each of the different regions.
Almost always I'm using 22 gauge. I mean, 50 millimeter, 70 millimeter.
Okay.
I use 70 millimeter for everything except for Express technology. The Express HAs, I use 50 millimeter. The reason why is because it's too much pressure to blow it off.
Okay.
So you have to use 50 millimeter.
So that's a good pearl. So for the expression technology, you'll use a 50 millimeter, just so that you don't put too much pressure.
Okay, so I wanted to show you one more technique. Is that if I come as I'm pulling out right here, I lay a little bit more right at the oral commissure, and this helps to lift it also.
Wonderful.
Okay, so do you see that? Look what's happened to her oral commissure from where we started to where it is now.
Beautiful.
And she's now got a smile, so no more frown.
No more frown. And you use a total of basically 3 cc's.
No, I ain't that. This was half a cc, and this was half. So I'll use about 2 cc's total. 1 cc upper lip, 1 cc lower lip.
Okay, so you don't like big lips.
Oh. We can talk about that the after hours.
All right.
Sorry. Okay.
But I think we need lips that are gonna fit to the person's face. And
yes.
so before we go on to my patient,
I'll make more point on the lips is that because I just made one poke there, the patient can then put on lipstick right away. Okay, and she can go out. All right. So we're running a little bit low on time. Okay, I'm gonna go ahead and show you the temple now. So this is an area that people always ask a million questions of. I don't think this is something you should treat as a novice. I think it's an expert to treat it. Arthur Swift talks about 1 up, 1 over. Temporal adhesion line, 1 centimeter up, 1 centimeter over. And this patient, if I did that, there's a large vein right there. So that wouldn't be great. He goes down to the bone. In this area, there's no major arteries in that area. The product, he holds his hand here, the product then works its way down. I think it's a great way to do it. It's not my preferred technique. I like it something using a little bit different. I can put my finger here. I can actually feel the STA. There's the STA. It's bounding like crazy. Want to feel that? Feel that.
And there's anastomosis from this to the supraorbital.
So the key to this is the plane. So I stick that in now. If I see a gush of red, then I know I'm in the wrong place, and I pull out. And I hold pressure. If it's dry like that, then I know that I don't have any major STA there. Now I'm in a plane. Okay, so what plane am I in? I'm on the superficial layer of the deep temporal fascia. Okay. And how do I know that it's a bloodless plane in theory? And if I'm in this plane, you can't see my cannula right now.
Because you're deep. So you are not in the superficial fat pad, basically where the superficial temporal artery is sitting right on top of the superficial fascia.
So the artery is in the temporal parietal fascia. It's on the superficial. It's above me. So I'm below it right now.
You're below that fascia and that superficial temporal artery.
And if I'm in this area, I know that I can work. Now I just did a forehead lift yesterday. So this plane is a plane that we commonly use in forehead lifts to get down to the diagonal wall.
And we know from the video that the anterior and deep temporal vessels are 1.5 to 2 centimeters posterior to that orbital rim.
But they're so deep.
And they're so deep. They're actually almost close to bone in that almost spongy plane below the temporalis muscle.
Okay, there's something else I want to show you. It's a very important point.
Yes.
When I move my cannula, do you see how it's gentle movements?
Yes.
It's not stabbing. It's gentle. And it's a rolling movement. That's critically important. Now I come over to the orbital rim here, and I'm filling in along the orbital rim, okay? So it's a gentle movement, and I inject on retrograde, okay?
And you're using, again, the 20 mg per ml expression technology gel.
Yes, but I thin it.
You thin it, okay.
So I have a cc of
you do a 1-to-1. Yes, and that's a very common thing that we see also
with colleagues that use the hyaluronic technology.
Okay, so what happens if I hit a vein? I've done it before, and the whole area just starts to go.
Okay.
I hold pressure.
Yep.
And that's usually enough to stop it.
Beautiful.
I've had a patient who came back with bruises everywhere, but that's it. Then after I do that, I just massage the area, and the product works its way throughout that whole space. It has an avascular plane that works its way all the way down to the zygomatic arch, and it fills in nicely. And over the next few days, this will continue to fill in, and it'll soften this orbital rim. It's a very nice technique on that plane in avascular. The key is getting into that plane, and I will tell you that many people don't struggle with that, but once you get that plane, it gently glides in there.
And so you can see with her that building that little bit of temple really was able to lift her brow up a little bit. And Sebastian Cotofono and a group of us just recently published the benefit of using the 1cc HA gel and being able to effectively lift even the mid-face from this point.
So but you talk about doing it posteriorly. Yeah, and then actually just doing depots.
Yes.
So depots posterior will lift it here. It's not usually the technique I do, but it's something to consider, yeah.
And you can see that softened things out versus this area that's a little bit more concave and has more shadow. So please keep asking those questions, guys. I'm going to actually take one of them, but we are going to be switching over now to my patient.
Okay, great. So I'm going to go ahead and do the other side while you get busy with your patient.
Wonderful.
So she doesn't leave just with a half a face.
Sounds like a plan.
Thank you.
Here we go, guys. And so this is my patient that I injected. And so people were asking about the DAO and the platysma. And so anytime that I inject the DAO, I always treat the platysma. With the DAO, I do 4 units of ano botulinum or inco botulinum. In this case, I am doing 10 units of avobotulinum. I do a 1.5 cc reconstitution, especially if I'm treating the lower face with avobotulinum toxin. And I always treat the mentalis as well. I always will do my neurotoxin first before treating filler on the lower face, because otherwise I will numb the platysma and not be able to have the patient engage, say E, to show me her bottom teeth. Now you're seeing me inject PLLA. She's a beautiful 39-year-old female who has never had any injectable filler. And so with her, her main concern is actually her acne scars. So the reason I love PLLA is because it's an excellent opportunity to address not only some of the maxillary bone resorption that she's experienced, but also stimulate some collagen production and improve the quality of her skin and get what some people call a PLLA glow. So you can see me, I'm using a 25/5/8 long needle to do little depots down onto bone. And I used 1 cc on her right side and am now using another cc on her left side. And so I reconstitute in my practice with 8 cc's of bacteriostatic water, which I find is a little bit less stingy than sterile water. And then I add 1 cc of lidocaine with no epinephrine. Now you see me at the base of the maxilla. And so just like what Stephen had talked about, I usually build laterally and then I build more medially. I'm doing little depots along bone. Whether these depots create more bone formation or have greater osteogenic potential than if we do linear strands across, the bone, basically on Sooth and the deep back pads,
We don't know. All we have is that paper that I had mentioned that Tatiana Pavlovich had published comparing cannula to depot techniques on bone, and she saw that there was equal amount of volume on both sides. So now I've injected a total of 1.5 cc's of PLLA on both sides, and now I'm moving on to doing little numbing dots. She was bleeding quite a bit, but you can see that we've controlled that bleeding with pressure. And so now I'm going to switch over to a cannula because I wanted you to be able to see both. PLLA doesn't just have to be done with needle. You can also use a cannula so that you can feel more comfortable with the plane that you may be injecting in. And so I love this technique, and this is the same that Stephen had used because it creates a little bit of hemostasis in the area that I'm going to use and introduce my pilot needle into. And so that's what I'm doing here. I don't like to mix epinephrine with my actual PLLA. And so now that I've built the lateral zygoma and a little bit of the bone with the maxilla, now I'm going to take my PLLA. I'm using a 22 gauge 50 millimeter long cannula. You can see I use my opposite hand to make sure that I am under septum below orbital bone. You can see me doing that again. I lift my cannula up. I know that I'm not in the superficial fat pad. I actually access the fat pad, the deep fat pads from this plane. And I always lift up so that I know that I'm also not diving into the infraorbital foramen where there's a little cuff that can actually hold and bound down the tip of my cannula. So that's why I always lift it up, especially if I'm kind of near the mid-pupillary line. And I wiggle my way up, and I'm basically coating the entire soup. The medial soup starts at the mid-pupillary line and then becomes lateral soup, extending all the way to the orbital bone. And at that level of the orbital bone, you no longer have soup laterally from that point covering the zygoma. So you don't have much fat pad covering the zygoma lateral from the orbital rim, which is why I actually like this product, because then you don't see, like we start to see with some of the HA gels on bone, sometimes more laterally in the zygoma, you actually might see like lumps and bumps. This product causes a more smooth transition. And so I've injected 1 cc of product there, and now I've worked my way up. So I'm pulling up on the zygomaticus major muscle so that I feel comfortable in the plane that I'm in. So I'm in the deep fat pad. Here's another angle to kind of give you guys a more aerial view. I am not superficial. You cannot see the gray of my cannula. I'm going to change techniques in a moment when I'm injecting along her buccal fat space on the skin in that area where she has her acne scars. Here, for instance, in this lateral cheek fat pad, which is a more superficial fat pad, you can see that I am more superficial. Now, in this area, it's a more fixed plane. You have more, especially in someone like this who's young, more adhesions between that skin and SMAS. And so, and because she's had acne scarring, there's a lot of atrophy and scarring that those scars have caused. So now I'm just doing these little thin little strands. You can see I'm fighting more than I was when I was really into that deep fat compartment. You can see how much I'm struggling because she's had so much acne scarring. And so here I do very thin strands, like 1 cc with each 50 millimeter long strand, because I'm not trying to make her bottom heavy. I'm just trying to take advantage of the biostimulatory properties of this product. And so here again on the other side, I do the same, and I injected pretty much about 1 cc on each side. So here I'm superficial, guys, because I'm not trying to get into the parotid gland. I want to stay nice and superficial. And so on the same day, you're going to see me, and I'm withdrawing back. So even though I'm using a cannula, I would draw back. You can see me kind of flicker, and then I inject because I have successfully been able to cannulate the infraorbital artery with a 25 gauge cannula. So now I'm using a Nasha gel, the one that has the highest G prime that's approved with cannula and needle on the cheek, off label here on the chin, and I'm building her pogonium.
I do like to use a needle. I'm using a 27 gauge needle because in some studies done by Yanni von Logum, as well as Susan Winkle, when you withdrew back and you held at least for 8 seconds, you can get a flashback. So you can see the distance between the base of her nose to her upper vermilion is about 1/3, and the lower vermilion to her menton is now 2/3. And so we have ideal proportions there. Now I'm blending on it by injecting her Nathian. And so in total, I'm going to be injecting about almost 0.8 cc's into the chin itself. And so now I kind of start moving laterally. So in a woman, you want the width of the chin to be about the distance between both medial canthi. In a man, it can be the width of both oral commissures. But I still do like to fan the chin out, because if they have a huge chin and they're even greater than 40 and already getting a pre-gel sulcus, you're only going to highlight that pre-gel sulcus more if you do not blend in. So now I'm taking my second syringe of the same 20 mg per cc Nasha product, and I'm just fanning a little bit along the pre-gel sulcus. So now I am injecting the posterior segment of the ramus of the mandible, which is a vascular plane that Andre Braz and I have published on. And so here I do little boluses because this ramus is resorbing. It's actually thinning out, and that's what supports our lateral cheek back compartment, our SMAC. And so I put little boluses, no more than about 0.5 cc's on each side, and then I'll blend it in. And in a woman, I take the tip of my cannula and take it all the way up to the earlobe to create a more mandibular sweep. And I do it on both sides. Now, Alex asked, hi Alex, nice to see you on. As patients get older, they will sometimes develop these huge deficits along the lateral inferior oral commissures. What is your approach there? You are going to see me do it right now. So you beat me to it. Here I'm using, for this area, I like to use either a Hyalocross gel that's 24 mg per cc, or this gel that's also using the expression technology. And I'm going to, it's Russell and Define, just, but you can use Ultra Plus. That's another excellent product for this area. I am under orbicularis oris. I take the tip of my cannula and I work it all the way up to the vermilion. And so I start from the mental sulcus midline, and then I kind of fan my way all the way to the oral commissure. And this is that deficit that you're talking about. If you build a cheek on someone and you don't bridge this transition between the lip and the chin, then you're only going to make that look worse. So this is a great and excellent way to support the depressor labii inferior muscle as well as the DAO, and bring the corners of the mouth up. But that's the reason why I do my toxin beforehand, so that when I ask her to engage her DAO, or I engage her mentalis, or engage her platysma, she will be too numb to do so if I treat her after I've done her filler, because there's all this lidocaine in this product. And in this area, to do this, I've injected 1 cc. So I'm up at the corner of her mouth. I'm struggling with that ligament that Stephen had mentioned, but this is how I go from below, or you can go from above. And you can see that the tip of my cannula is almost above. So it's like a little flagpole that I create, but I'm under muscle. And then lastly, I go into the lip to build the lip. And this person, unlike our last patient, she had no lip. And she had a pretty wide wide cheekbone, and she's pretty young to have a very small lip. And a small lip, adds to our femininity. It does add to, how I think not only make someone feel, like Stephen has talked about, maybe they feel happier, but they also, I think, they look more approachable and more feminine.
when they have a little bit more of a lip. Otherwise, it looks straight and it looks a bit angry. So that's a future study. How approachable does someone look with a lip that's a little bit bigger? And so what plane am I in? I'm essentially in muscle at this point. When you don't see the gray of my cannula, there's only one product that's a Vicross gel that I will really attempt to see the gray of my cannula, and where I really want to be on top of that muscle. Otherwise, I don't know if the other gels are forgiving enough to be on top of the muscle. Now I will switch over to needle because I think that you need both. And this is to really outline the Cupid's bow. So here I am along the vermilion border. And I think that that gives that central aspect of the chin a little bit more definition. And you're going to see her immediately after injection so that you can appreciate it as well. And so, this is where I switch over to a needle. And then lastly, now I'm going to my neurotoxin. So I, unlike Stephen, do my neurotoxin at the end. I think that we all have a certain threshold for injections. And so I'd rather them be fatigued by my injections at the end of my treatment, instead of if I was doing filler at the end in these areas, then she might be jumping and moving on me. But since I'm just doing neurotoxin, and I'm using a 1.5 cc reconstitution here, so very tiny little drops, because we, anecdotally have heard that this product does diffuse a bit. I do 1 unit or 3 units of avobotulinum toxin into these 2 little drops, one mid-pupillary line immediately inferior to the eyelash, and then again a little bit 1 centimeter out and 1 centimeter posterior. I do another 1 unit. And that's not to efface wrinkles. That's not my goal. It's to open up the eye. And so that concludes her injection. And then you can see her like 20 minutes later with ice. You can see that she barely has any real bruising or swelling. And I tell them that the product's going to integrate over about 2 weeks with their HA gel. And then that the Sculptra or the PLLA will continue to improve for about 8 weeks after injection.
Very impressive.
Yeah.
So 2 different ways of doing it, both with really good results. I think you can learn a lot from both.
Yes. There's more than one way to skin a cat.
And usually one way is a little bit better than the other.
Sure. Whatever you need to tell yourself to make yourself feel better.
Are there any questions?
So thank you so much, you guys. I appreciate all your questions. You guys have done such an amazing job. Alex, to your point, I do like to use a cannula when I'm transitioning from the chin to the oral commissure in those areas that are a bit more sunken, just because I do think that, as you saw in my anatomy lecture, there's a lot of blood vessels that are anastomosing underneath those muscles in that area. So it's a good way to avoid those vessels.
Okay, it's great. So I think we're coming up on the end of the session.
Yeah.
At the end of time. I do want to thank Bryn Mawr Communications, who made this all possible from here, and those who gave us a grant to make this happen.
Thank you, Galderma, for sponsoring this with your grant support.
And we have another show coming up. Our next one is October 14th.
That will be on a Wednesday, and that is a bright eye session where we're going to be covering everything about the eye.
And we're going to do that for breakfast, I think, right?
Yes. And so we're going to be doing that to keep you guys, you guys are going to be nice and bright-eyed at about, I think, 7 in the morning.
So we'll have to bring our bagels and our coffee to that one.
So thank you again for joining us, and make sure to follow us on Instagram Live immediately after this CME session.
See you soon.
Bye.
Bye.